Can you see my slides there? Yeah. Great. Okay. So
Perfecto.
fantastic. So first of all, thank you so much for the invitation. I've been in Brazil for several months, but unfortunately I'm in London now. Otherwise I could have come to visit you. So next time. And the title of this is basically, wasn't it enough with HIV and COVID? What about monkeypox and the virus emergence? And I'm going to cover some of the things today about the history of monkeypox, the virology, its transmission and epidemiology, how to test for it, and the clinical picture. And I'm going to have a few slides on HIV and about the treatment and vaccines. So the monkeypox virus, if you look at the bottom here, well, the first outbreak was in animals way back in 1958 when I was 2 years old. And it was discovered by this von Magnus, and it was in a laboratory animals that was sent from Singapore all the way to Denmark. It was found to be a DNA virus, double-stranded, and an orthopox virus. Well, after that, we then saw the first case in 1970, that's 12 years later, in the Congo in a 9-month-old boy. And since then, monkeypox has really been endemic to Central, West and Western Africa in two various clades, clade 2 and clade 1, and I'll discuss that a little bit later on. So here it is. It's got an envelope. It has this core membrane with fibrils and a nuclear protein in the center here. And it's interesting to know that some of the virus has this as a special envelope and other parts of the virus don't. And here it is. So here it is as a mature virion and an enveloped virion. The mature virion is mainly intracellular, and then when the cells break, the virion's released and gets phagocytosed back into other cells. And there's a circulating virion which has got an envelope. The difference between it is there's one extra layer in the enveloped virus. And you can see here, it releases viral DNA, which is transcribed, and then various proteins are produced. And there are two pathways for these to be produced, early on or later on. And then you form either enveloped or this other mature virion. And as I say, the mature virion stays inside the cell until the cell breaks, but the enveloped one can come out by exocytosis and circulate. So it's a very complicated life cycle compared, say, with HIV, but it's very interesting. Now, where is the animal reservoir? Well, it's really unknown, but there is evidence that various animals can have mpox. So there's squirrels and relatives of squirrels, I think called a shrew, and I've got some pictures of these here, and also rats. Now here you can see an American family with a pet, and this was very, very common in the US. People had these little pets called prairie dogs, and these prairie dogs had monkeypox and they transmitted it to their owners. So they were then banned from the US. They came out of West Africa. And of course, we know that non-human primates and humans can also be infected. And here's the transmission cycle. Out of these little rodents, it gets infected into monkeys, or as I've said with the prairie dogs, direct to humans, and from monkeys to humans here, and then human to human spread, as we know. So this is a sort of life cycle. It's a proposed one. Now, what about the genetics of this? Well, mpox is a member of the orthopox genus of viruses belonging to the poxviridae, and so it's closely related to cowpox, vaccinia, and canary pox. Here it is here. Here's vaccinia, here various strains of cowpox, and distant related here to variola, smallpox down here. So it's part of the whole family, and you can understand when you see the clinical presentation that it behaves quite much like a pox virus. Now, the clades. There are two clades that have been generated, clade 1 that have evolved, clade 1 and clade 2. And this is the one we need to know about. It's clade 2 and especially the clade 2b. And this is the one that circulated in the global outbreak. And it's interesting that clade 2 and especially 2b is a milder disease, and that we must be thankful for that. Fewer deaths, less human-to-human transmission, and less viremia. although if you compare clade 1 and clade 2, there's no difference in hospitalization rates, illness severity, or pronounced rash. But this data comes out of Africa, where you may not have as much diagnostic capability and only the sick people end up in hospital. And the severity of the disease was independent of age or vaccination status. So here we are going back in time and the evolution of monkeypox. And in the red is the one that we've seen in the region of the Americas here, and in the European region, the little blue dots as well. So this is clade 2B1 mainly. There's been some A2, clade 2BA2 as well, as you can see. And here's the clade 1, almost all remaining in Africa. And monkeypox has been evolving here. You can just see this evolutionary tree with it evolving throughout the world. Here's some Indian strains, Thai strains, UK, Portugal, and it's carrying on evolving. But luckily, it doesn't seem to be associated with worse severity. So why is it that we saw monkeypox? Sorry, I've got feedback here. I'm just going to take off something. If I can. I'm really sorry. It's disappeared now, so I think we're okay. So if you look at the timeline from global smallpox eradication program here in the 1960s, it finished in the 1970s. And then what happened was that you can see here in 1980, when the vaccination stopped, there was a hiatus. And what filled this hiatus, what filled this niche, was monkeypox. And it's thought that once smallpox disappeared, there was a niche for transmission of monkeypox. And perhaps monkeypox was competed with smallpox back here, but actually developed into the epidemic because smallpox had disappeared. And you can see here before 1990, the countries in Africa that were affected, and then more countries and more. And you can see this is the state of play up to 2017. And most of the transmission was thought to be contact at that time. But in 2017, there was a suggestion that sexual transmission in Africa was taking place with monkeypox. And of course, that's got great relevance to the current outbreak. Now, let's have a look what happened in Nigeria over the years. Here in one of the, Nigeria's got many states. It's a bit like the United States of America. It's the United States of Nigeria. There were some cases presenting in these various states here. And you can see back here in 2019, a Nigerian traveled to Singapore, and there was an outbreak in Singapore and then in UK. So this was basically transmission from somebody who had monkeypox in Nigeria who traveled. And then you can see again in 2021, someone traveling to Israel and the US. And then what happened was in 2022, we can see that people started to travel, and there was cases reported, especially in the UK. But now something different happened. And what happened was the initial case came imported in the UK from Nigeria in May. And then 2 weeks later, there was a second case, but they had no link to anybody from an endemic area. So then suddenly it was realized that there was person-to-person transmission within the UK without any link to Africa. And then suddenly gay and MSM and gay and bisexual men in other European countries started to develop monkeypox, and associated with large gatherings and parties and sex parties, all of these started to be associated. So we then knew that it was imported from Nigeria and then started to spread locally. And it was incredible. From May 7th, the first case, to July 23rd, just 3 months, who declared this to be a public health emergency of international concern. And by December, 9 months after it started, there were 82,000 cases in 110 countries and 65 deaths. This was like a fire. It really erupted across the world. So what are the global numbers now? You can see there's been 87,000 confirmed cases. Luckily, the death rate's low, 120, but still 110 countries reporting cases. You can see in the white, we don't know what's happened, but in the other colors, you can see the density of the cases, and the dark blue is where there have been more than 1,000 cases. And here's Latin America for you to look at. More than 5,000 cases here in Brazil, and here in the United States, and you can see between 2,000 and 5,000 or up to 1,000 in the different colors and the different darker colors here. And if you really want to go down deeper into what's happened, US had about 30,000, Brazil 10,000, and if you look at Chile, nearly 1,500 cases. Peru and Mexico had a few more. So I've just put every country here that's had more than 100 cases. Now, you can see here the explosive rise in cases. Now, the region of the Americas that WHO presents is both North and South America, and you can see here this massive rise. And I remember in May talking to people and saying, hey, we should do something on monkeypox. And the US guy said, oh, no, we've only seen 1 case or 2 cases, not worth doing any seminars or anything on monkeypox. By the time July, August came, they were changing their mind and saying, yes, it's a major problem. And I think any of you who went to the International AIDS Conference in Montreal in July 2022 know how serious this had become by then. Now, the interesting thing is that there's been a big decline in cases. So why is that? Well, could it be behavior? Some reports have said, yes, people have changed their behavior, had less partners, and others, especially from Italy, have said no change in sexual behavior in numbers of partners. So that is still unknown. What about vaccination? Well, vaccination hasn't been worldwide, yet the numbers have gone down. What about the principle that everybody who was at risk of being infected have been infected, and once they're infected, they develop immunity and don't get infected again? So maybe what we saw here at the peak was the sort of target audience, all the people that could be infected have got infected, and after that, the numbers have gone down, and maybe the people with risk behavior, which was very minimal, have retained that risk behavior, so haven't got infected, and lots of people have got vaccinated, etc., etc. So it may be that the reason it's gone down is all the higher risk groups have got infected rather than behavior and vaccination. But it's really going to be interesting to try and find out why it declined so quickly. So how's it spread? Well, direct skin-to-skin contact, and it's very interesting. If you have sexual contact, that's where the lesions start usually. You can get it by contact with objects, clothes and linens that's been used by someone who's got monkeypox. Very rarely exposure to respiratory droplets or oral fluids during prolonged face-to-face contact. And of course, pregnant women, people to the fetus. And individuals remain infectious until the scabs have all fallen off and a fresh layer of skin has been formed. And we now know that sexual contact has been a major way of transmitting Mpox. So let's look at the cases. So if we look at the profile, this is data up until April, about 85% have been in men who have sex with men. There are a lot of missing values here, but in the ones where we know that's been the case, and again, about half of them have been HIV positive. Health workers, many of you are in the audience, most of you, it's quite rare, but the issue here is that some health workers are MSM, some health workers are HIV positive. Travel history as well has been important, but you could have traveled from, a lot of people do travel, and it could be that you've still got that in the country of your origin, although you've got a history of being on holiday somewhere where it's common. Sexual transmission, 82%. But as I say, very few hospitalized, very few get into an intensive care unit, and very few have died. If you then look at all the cases, but take away the MSM, so don't include in this data MSM, so we have no MSM here. Now, if you look at HIV positive, it's much less. So these are non-MSM HIV positives. Health workers is about this, a little bit more, 8.7%. Travel history less. Sexual history, though, you can see transmission has gone down a bit here. Hospitalized has gone up a bit. ICU about the same, and died. So it's interesting the impact of being MSM on the sort of case profile. Now, what about testing? Well, you can do reverse transcriptase PCR or conventional PCR, but the problem is it's much better to have a specific Mpox virus test, because there are orthopox viruses which cross-react, and some people have been saying to me that maybe 5 to 20% of some people in some areas of the world may have been infected with other orthopoxes viruses, which may give you a false positive. So it's really important when you interpret the test that if they've got a very low probability, there's lack of an epidemiological link, that non-MSM, the signs and symptoms are inconsistent with monkeypox, they might have a false positive result. And obviously people have been doing sequencing to look at the clade and to understand the epidemiology. Now, semen is important because it's been found in semen up to day 11 and other studies even further on. It's unclear, though, whether this is from lesions in the penis or urethra rather than the semen itself. So as the semen passes through it gets virus. And what is said, men who have had confirmed or highly probable diagnosis of monkeypox should use condoms during sex for 12 weeks after recovery, which is quite a long time. And the case definition, everybody's got their own case definition, but most of them include rash, fever, lymph nodes, and then other things, headache, backache, fatigue, chills, and mucosal lesions. And now what's included is a single rectal lesion could also be monkeypox. So anal rectal lesions have been included in the definition. So here they all are. How do you diagnose it clinically? Well, it's like a viral illness. Most of us have had viral illnesses with chills, muscle pains, backaches, fatigue, and then you develop lymph nodes and skin lesions. And you can see here, if you collect all the symptoms together, you can see that most people have had a rash. Most people had fever or feeling unwell. A lot of people have had a genital rash. And you can see here headache, muscle pains, etc. And then some very rare things, including, which isn't on here, I don't think, a CNS involvement and other issues. So let's look at what it does look like in Africa. It's a lot of monkeypox is in children. Here it is, widespread, affecting the body, and you can get genital lesions in these children. You can see them here, and they can get complications. You can see keratitis, staphylococcal infection, calcification of eye lesions, dermatitis, and edema. And we've seen genital edema here in some of our patients. So, and this is how it presents as an African monkeypox. So the incubation period's up to 3 weeks, from 1 week to 3 weeks. The symptoms tend to start after about a week after the first contact. And that's important when it comes to prophylactic vaccines. And then what happened was there was a sort of an unfolding and a revelation of the disease. It started with fevers, chills, myalgia, fatigue, typical viremia. And then you got a rash, usually on the face, and then spreading, often sparing the genitalia. This is what we see in Africa. Most of the people were young, and the people that got it worse were children, pregnant women, and the HIV immunocompromised. But what we've seen now is the incubation period slightly longer, 8 days. There's a loss of classic pattern now. So instead of getting chills and fevers and then getting the rash, some people start with the rash. And actually, a lot of people with chills and fevers chills, fevers, and headache, it's shorter. And as they say, sometimes they get the rash before. The other thing is the lesions used to evolve from one stage, from a sort of a blister, and then they'd heal up and then they'd get better. Then all the lesions would do the same thing. But now we're seeing them all do things at various stages. And of course, we see more lesions in the anal genital area and not so much outside of the anal genital area. And we've also seen a lot more oral and rectal involvement related to where people have had contact with the monkeypox through oral sex or rectal sex, and also a lot of lymphadenopathy, however, low hospitalization rates. And here's just the study showing how much people have reported fever, headache, lethargy, and pharyngitis. Lots of studies showing all of these things. And here's the eruptive phase. You can see these small lesions starting here. And in over half to 3/4 of cases, people have less than 10 lesions. And I remember we had a case with a patient who just had a lesion on the forehead, right there, single lesion when we made the diagnosis. So it can be difficult. Imagine you have a single lesion perianally you don't know about, or a single lesion under the foreskin, etc. You may not notice it, or under the scrotum. But there you can see, so you can do that. And it takes up to 2 weeks for these lesions to start healing. You can see it all healing up here and crusting over and new skin forming. And you can see perianal lesions here, and these can be extremely painful. Okay, these can be extremely painful, and they can, here's some of the lesions of the penile lesions evolving over time and getting better. And here are some of them. Here's a sulcal lesion causing a big ulcer. Look at the size of this ulcer, very painful. And again, a perianal ulcer, really causing problems. And these can get badly infected with secondary infection. And you can also get lesions elsewhere on the body. Here's a person who's just got one on the hand, which is getting better. So his skin lesions on the limbs or face and neck. And here are some complications with big oral ulcers. I've shown you anal and rectal ulcers, and these can be very severe. Here's a big ulcer on the lip, all right, and here in the throat. And proctitis. Some people can present with proctitis, and you look inside the rectum and you can see a single large ulcer. Obviously, you have to, though these are usually painful, you have to exclude syphilis. You have to exclude various forms of chlamydia, and you also have to make sure they haven't got any other STD. But now one of the differential diagnoses is monkeypox. Encephalitis can occur, and it used to occur in smallpox, and it can occur in monkeypox too. And you can get edema as well of the penis. So there's lots of issues to do: pain relief, antibiotic treatment, etc. So here's some perianal lesions, and here's some lesions inside the rectum here, and you can see they've been described by a lot of people. So what can you do? Obviously, if it's infected, antibiotics. You can get bronchopneumonia. People have given empirically acyclovir for this, which is strange, but now we have tecovirimat. It's very rare. Secondary bacterial infection is common. So skin care antibiotics. Encephalitis, people have given this, but now we have tecovirimat. And women who are pregnant can have miscarriage, gastroenteritis, and also eye infections and keratitis. Now, don't forget that anyone with monkeypox should have a full STD, sexually transmitted disease screen. And when you look at that, you can see that people can have HSV, herpes simplex, and I think that's why people give acyclovir as well if you're getting encephalitis, in case you've got two diseases at once, and also syphilis as well. And you can see that people have gonorrhea, chlamydia, and about 7% have 2 or more sexual diseases, and 4% have new syphilis. So please, anyone with monkeypox, test for other STDs. What about HIV and monkeypox? And these are some studies of patients who had HIV or compared with non-HIV. And interestingly, look at this 9% of the patients who came in with monkeypox, it was the first time they had an HIV positive diagnosis. So anyone with monkeypox, not only do an STD check, but of course HIV should be tested for, because that is an STD that we need to diagnose. Now let's have a look at those patients who have a CD4 count of less than 100. First of all, they get more fulminant monkeypox. And when I was in Brazil, I saw some cases of this there. They're usually patients who are viremic, who've got a very low CD4, less than 100. They have disseminated necrotic lesions. They have extracutaneous complications like encephalitis, pneumonitis, and they get more intensive care unit admissions. The lesion burden, the lower the CD4, the more lesions they have. Anorectal involvement's twice as likely. They have concurrent opportunistic infections. So not only do they come in with monkeypox and a low CD4, they can come in with other opportunistic infections. And now monkeypox is defined as an opportunistic infection in HIV along with all the others. Pulmonary involvement more common, and CNS involvement. Almost every case of CNS involvement in monkeypox, almost all of them, have been in patients with HIV with low CD4s. And here are some other pictures of pulmonary involvement, of involvement elsewhere, of large disseminated necrotic ulcers. You can see really, really very sad. You can see very nasty problems. And you can see this patient here absolutely covered in lesions. And we've seen, like many of you who lived through the era of when we couldn't treat HIV, the large CMV cutaneous ulcers, the large HSV cutaneous ulcers, which were necrotic and large. Similar, we see that in monkeypox in advanced HIV. Now, we've also seen IRIS. Immune reconstitution inflammatory syndrome occurred in some of these patients with advanced HIV who started antiretrovirals at the same time of active monkeypox. And of course, except for cryptococcal meningitis and perhaps TB meningitis, we tend to start antiretrovirals with any opportunistic infection. And we've done that with monkeypox. But look, 12 of them died of those who developed immune reconstitution. And there's a concern there. So when should we start antiretroviral in people who are newly diagnosed with advanced HIV and concurrent fulminant mpox? Should we delay antiretroviral therapy as a safer strategy? And we don't know because we don't have enough data. So it's difficult for us as physicians to make the decision. Another US report recently from last week looked at 57 persons who admitted to hospital. These were Black or African Americans mainly. Look at this. Social factors in monkeypox, 23% were homeless. 82% of these 57 people in hospital had HIV, and most of these had less than 50 cells. A third needed intensive care. 20% died. Nearly all of them had HIV infection. And less than 10% of the people with HIV, here they are, that's about 40 patients, were taking antiretroviruses. So you can see that if you see a patient with monkeypox who's got a low CD4, who's HIV positive, really you have to treat them very carefully and very quickly. If they've only got a few lesions, really start treating them as soon as possible, if you can, with antivirals against monkeypox, because they could progress rapidly. And if they come in with fulminant infection, then there's a high death rate. So what about treating it? Well, there are 3 US FDA-approved drugs for the treatment of smallpox, which is tecovirimat, a favorite drug of ours from the past, cidofovir, and a sort of generation of cidofovir called brincidofovir. And there are 2 FDA vaccines for the prevention of smallpox, the ACAM 2000 and the Genius type of vaccine. Now, the approval of all of these drugs and vaccines have only come through animal models. There's been very few clinical trials, and we recently started some clinical trials of tecovirimat and these vaccines. But of course, with the numbers going down, it's been difficult to recruit to. So what about tecovirimat? That's been authorized by Europe and the FDA for treatment of monkeypox. But you could use cidofovir or brincidofovir. And then there's the Vaccinia immunoglobulin, can be considered also for severe case and for maybe people who've got severe T-cell dysfunction, which HIV patients have following exposure. So there are some other antivirals in development. Here they all are. And it's interesting to see HPMA, which some of you may remember was used in HIV, and ribavirin here, which has been used, of course, mainly in hepatitis. So what about tecovirimat? It was approved in 2018 for smallpox, and it basically affects, stops the Golgi-associated binding here of the virus required for its maturation. Most of experience has been in disseminated vaccinia virus infection. And as I say, there is some accumulating experience and there are randomized trials, but they really haven't been recruiting. You dose it with 3 200 milligram capsules twice a day for 14 days. And I would say that in fulminant HIV immune suppressed patients, I think you might be able to, you might need to keep it going for even longer until the lesions have healed up. You can get some adverse reactions. It's mainly headache or GI, and you have to be careful in renal impairment. It is a weak inducer of cytochrome 3A4, and it's really only rilpivirine that you have a problem with. Here are some of the adverse events. If you look at placebo versus tecovirimat, it's basically, and you look at the percentages here, all the percentages are similar to placebo. So it's a relatively safe drug as far as we know. We do not know about the development of resistance to tecovirimat, but it's probably got a low barrier to resistance overall. And here it is, tecovirimat. It's really only rilpivirine that you have to be very concerned with. Many countries don't use rilpivirine. However, I have no idea what would happen if you were on injectables and took tecovirimat. Here you know about cidofovir very much indeed, and it causes nephrotoxicity, and brincidofovir is orally available prodrug of cidofovir, and so these two are options as well if you can't get hold of tecovirimat. Vaccinia immunoglobulin, no real data, and it can be considered in post-exposure prophylaxis. And there's a couple of sort of anecdotal papers here about the use of tecovirimat in someone with acute myeloid leukemia after smallpox vaccination, and somebody here given vaccinia immunoglobulin. Now, what do the CDC say about the treatment? People with severe disease or people who may be at high risk of severe disease. So I would say if you're HIV positive and you come in with any lesions, you should go on treatment as soon as possible, especially if your CD4 count's low. And anyone who's got complicated, and that includes proctitis or anorectal lesions, definitely you've got to think about treating them. So anyone who comes in with lesions and they're immunosuppressed, really think about treating them straight away. And here they are, anyone in the eyes, mouth, or other anatomical areas, including the genitals or the anus. Now, what about vaccination? So this is AChem 2000, and it's replicant competent live virus vaccine. And I would say this is a no in HIV, especially immune compromised patients. The Genios is a replication defective live virus, so that's a yes. So because there's no risk of dissemination. This AChem 2000 could disseminate. And the Genius shows animal models do show protection against monkeypox. So we got limited human data, though it seems to have worked so far in what we've seen. And here we are just comparing the two. Significant events can occur with the live virus, including myopericarditis. There's very limited data on the Genius, but no real significant effects. And the effectiveness, well, it's very interesting that the immunological response to the Genius vaccine in HIV patients doesn't look as good after one dose, but after 2 doses is better. So if you compare HIV patients versus non-HIV patients, about half of them don't have a good response after the first dose, but I haven't seen the data by CD4 count yet. So that's interesting. And what the administration, the recommended one is subcutaneously, 2 doses 28 days apart. But this is why we wouldn't want to give the live virus, because you can get disseminated monkeypox from the live virus. I mean, disseminated vaccinia, sorry, from the live virus. You can get this disseminated type of picture. So do not give that. Give the Genius that it's live, but it doesn't replicate. This is the replicant competent one. So what should you do? Post-exposure prophylaxis, especially if you can give this, if someone's got known exposure, if you can give this within 4 days, some people give it up to 14 days, then you can give the vaccine. They had an expanded use of this for people who are known contacts who are basically who had a recent sex partner within the last 14 days diagnosed with monkeypox. And again, a certain gay or bisexual men of high risk, you should give prophylaxis to, and especially if they are HIV positive. And also people in occupational risk groups. So if you can do it within 4 days, it's best, but up to 2 weeks after exposure, you can also do that. So there we are, 4 days of exposure to prevent that. And it may reduce symptoms, but it may not prevent disease. So max vaccination, we've all been encouraging that, not for the general public, but or for all sexual active, but mass vaccination for our HIV patients, but and people at high risk of developing monkeypox. In other words, gay men of high risk. We've been doing that. And in fact, we vaccinated a lot now of our HIV patients. Most of them have been vaccinated, and also our PrEP patients. So I think that it's really important that they get vaccinated as much. Now, you can also do this. You can give a second dose of intradermal. So this is intradermal. Now, it's interesting. The intradermal seems to do a bigger reaction in the skin and give you better immunological protection. So you can give intradermal. The problem is, and of course, you use 0.1 mil. So you can give 5 doses out of 1 vial, but once it's been opened, the vial, you have to then use it all within 8 hours. So intradermal looks very interesting, gives a good immune response, and what we've done a lot is the first dose may have been subcutaneous and the second dose intradermal. And this is just sort of summarizing for people with HIV. If you've been exposed, give the Genius. It's called Imvanax in Europe. That's why I put the name there. Okay. And 0.5 mils or 0.1 mil intradermal, and a second dose after 28 days, whether or not. And what people have said is they've got a low CD4 count. Both of them should be subcutaneous, because we don't have great data on that. But on the intradermal, you can give it intramuscularly, but we've been doing subcutaneous. But I think that the intradermal might be a better route even in the HIV, but we need to know about the immune responses in our HIV patients in better. And there was a little bit of data from Croy showing how good it was. So with that, I'd just like to make the summary that Mpox appeared to have filled the niche that smallpox left behind after eradication. We had an opportunity for years, probably, to continue the smallpox vaccination, and maybe Mpox wouldn't have arisen. And in fact, it would be fantastic if all of Africa can get vaccinated now. We then saw that it came out of Africa into Europe, then into the Americas. They've seen it in 110 countries now, and it's mainly been clade 2B, which has got low hospitalization rates. It's the big transmission has been through sexual contact, which we have a hint of from Africa, but really in outside of Africa, it's the main way of transmitting. It's been mainly in MSM, and a lot of HIV positive persons have also had monkeypox. It declined almost as quickly as it rose up, perhaps because everybody who was at risk, a big risk behavior, developed it. We don't know how much behavior vaccination, and not much, I don't think, of treatment has helped make the decline come down. We've seen that it presented slightly unusually now. We don't get this progression of prodrome, rash, and then resolution. We can get the rash coming before the prodrome. We can get the rash at all different stages. We saw in the HIV patients, especially those with low CD4s, they have a high death rate, high admission to the intensive care, disseminated, fulminant, very severe and extracutaneous treatment. We have a vaccine, but we must use the replicative incompetent virus, the live virus that can't replicate, the Genios one, to give to our patients. And we can use it not only as prevention, but perhaps as prophylaxis with anyone who's been exposed. And we've got some treatments with tecovirimat and perhaps with cidofovir. And I hope that what's going to happen now is that we're going to eradicate it from Africa. We're going to reduce monkeypox throughout the world, and that we don't see another outbreak or an epidemic of this virus. And with that, I'd like to thank you all very much, and I'm happy to answer any questions.